presenter is also going to look at the past. We have Mark Cotton, who's a pediatric infectious disease professional who is based at Stellenbosch and Tygerberg. He runs a research unit there, and he too is going to look back, if I can find his presentation.
Good afternoon, everybody. So let's continue this tale. Now I have to work out how to make it go forward. Yeah, how about? Okay. So I want to go back to the first study that I did on HIV in South Africa when I'd just come back from the US and thought that I knew what was going on. I was very wrong. We decided to quantify the burden of HIV in children at Tygerberg Children's Hospital, and to try to use that as a way to illustrate through data the madness of the callousness of the policies that were going on at the time that Haroon has just spoken about. So we had about 90 children, and we added up the days that they were hospitalized and what happened to them, and we converted that to resource utilization. We weren't, obviously some of them passed away, but we just wanted to show, and we're not economists, so we just gave an arbitrary number or the cost of a day just to show, apart from morally, the extreme waste of treating something that you can prevent. A real landmark happened in 1995, and that was just actually before I returned to South Africa, and that was the start of triple therapy. So those are 3 ARVs, and it just works better than 2 or 1. And this is some data in children that showed the same thing, because this was very incremental. You got 1, you use 1, you got 2, you use 2, and then there were more than 2 available, and that seemed to work really well. Really, in the first year that I was back, we had a child who had acute upper airway obstruction, and this was turned out to be due to Epstein-Barr virus infection. And the real story is that this kiddie presented with upper airway obstruction. He had big tonsils, had a tonsillectomy and adenoidectomy. There was no ARVs at the time, and he was not in great shape. And he came back with acute cor pulmonale and was about to die, and we thought, we can do a tracheostomy. However, the intensive care nurses correctly were worried about their own risk, because infection control wasn't as well structured as now. And we said, well, what if we treat the baby with an antiretroviral, which we managed to get from the hospital? That'll reduce the infectivity, and then you're going to be fine. It's not quite correct, but it probably, there is something about that. And basically the kiddie recovered miraculously and was sent home, attended 1 follow-up a couple of months later, and then we lost him to follow-up. But we thought that's what was going to happen with antiretrovirals. We would beg for 1 ARV at a time from the hospital authorities, and then we would use it in a palliative way to get children home to their families. We actually did quite a few of this strategy and could actually show, and these were the first 2 studies that have actually documented ARV clinical use in Africa. But we showed using monotherapy that you could reach limited goals and you could get children home. And so in other words, you don't stick them with needles day in and day out, and they're not, and they're more comfortable at home. You know about this rising antenatal prevalence. David Bourne, who was a gifted public health specialist from UCT, what he did was looking at that rise in HIV prevalence, antenatally could link it directly to mortality in the first year of life. And he showed also this was mainly in the first 3 to 4 months of life. So showing you some extent of the problem. So now, amidst all of this, we're going to come to the SURE study and how this arose. And this was part of a funding opportunity through the NIH to increase clinical trial infrastructure in many countries of the world. Focus on Africa, Thailand, South America, and led by James McIntyre from WITS and now UCT and Inova. He put together a call to try to address, to build infrastructure for HIV care through research. It was quite sophisticated. We didn't know what we were letting ourselves in for. I got a call late one afternoon from Glenda Gray. I said, am I interested in this? Of course, I had no time, but I said yes, and became involved in some interlinking projects. And this was really a 3-university collaboration that lasted 11 years and was incredibly successful. And you can see it was UCT, Stellenbosch, and WITS. So the planning for the SURE trial began in 2001. This was really just applying for funding for this grant. At that stage, there was nothing, and very vague ideas. Looking at the world guidelines at the time, initially the US was treating everybody. In Europe, they were more conservative. The WHO was saying, let's treat sick children. And then the US backed down. They became even more conservative, or they became conservative in line with everyone else. And that's how things were. So we were thinking, should we be using early treatment? There are things for and there are things against. And I'm not going to read through all of these things, but you can imagine, some of the difficulties that ARVs could have as well, especially adherence, disclosure, and possible toxicity. Then some data came out linking CD4 count or percentage to severe disease and death. So the younger you were, the more things happened at a higher CD4. And that's the bottom line of that. And that drove policies as well. Early infant diagnosis in 2004 was pretty vague. And I've quoted directly from the national guidelines. So you would do antibodies in the baby if the mother's sick, or you could do it in the mother if the baby's sick. And of course, if the antibodies persist, it's beyond 18 months, it's HIV. And there's this new technique called the DNA PCR that can be used, maybe, at 6 weeks. So what we did was we looked at early therapy and asked the question, if we started treating early and we interrupted, would that be better than starting late? Because you would get the kiddies over infancy, and then they would they would be able to stop antiretrovirals for a time. So we continued, so we had the standard of care versus starting immediately for 1 or 2 years of age, and the idea there was that in a public health setting, it would be easy to stop at the 1st or 2nd birthday. Then we would stop therapy and we would restart again when needed. Looking at what happened at baseline, they started at 7 weeks of age, which is pretty good. And they had very high viral loads and were quite sick. We already had a hint that even at screening, a lot of them were actually quite sick, and a lot of them had severe CD4 depletion at screening already. During the first year, the results were, we had a data safety monitoring board who looked at this and said, look, you've got to stop recruiting into this deferred arm and release this data. It's quite important, very important. And there was a huge difference in mortality. When the children started therapy, they were screened to be asymptomatic and have high CD4s. If they had a lower CD4 or symptomatic, they would, or they could start antiretroviral therapy, and we had a small arm that was able to do that. So this really made a big difference. However, when we looked further and looked at children's brains, including those that started early therapy, we could show that there was some white matter problems, suggesting that maybe 7 weeks is too late. And because this included some children starting on ART at 7 weeks of age, and many of these were on constant antiretroviral therapy without interruption because they'd already met endpoints. Then we also showed that neurodevelopment was better, which is what we want with early therapy. And then we, 6 years, or after 6 years, we released the final results, which confirmed that most of the bad things were happening early on, and the benefits of early therapy persist even if you interrupt therapy a bit later. And there seemed to be, treating for 2 years might be a bit better than treating for 1 year. However, when we looked at what was going on in the field and looked at children accessing ART under 12 weeks of age, they were pretty sick already. So in the field, almost 60% of children had advanced disease under 12 weeks of age. So again, pointing to improving your program. One of the interesting features we learnt about, and that people are facing this occasionally, that if you're on early therapy, you lose your antibody. So it's no longer a test that you can use, and it doesn't mean that you're cured. So this is becoming more important now. Looking at what's going on in the cells or the HIV reservoir in these patients, early therapy reduces that reservoir a lot. So when it comes to the next generation of studies, these, looking for children who have very low reservoirs, and this may be a population to treat. So we thought we were doing very well treating at 7 weeks of age, and we know that it's taken time for the programs to start ART quicker, and we now have a birth PCR to speed up that process. And this is what is driving it. And this is the report of the Mississippi baby. This was a baby starting full therapy at 30 hours of age, who actually had a period of remission because the mother decided to stop the therapy at about 18 months of age and remained with undetectable virus virtually on every test for 2 years, suggesting that this is something we need to take very seriously, and also that we don't really know what's going on with HIV dynamics. So just to acknowledge some of the many people that have helped with this study, and we are looking forward to what happens next. Thank you very much.